Yeah, I think that I love to work with open-minded, innovative leaders, and I think that that's the majority of the health systems that we're working with now. They're looking to transition how things are being done because they're getting kind of caught behind the eight ball in a sense. Is they know that operationally things aren't working because there's such a higher demand for care right now. I like to say that we don't want to change internal workflows that are going on in the hospital. We want to enhance them. So that's why we embed that. We embed ourselves on units or in ERs to help, transition and make it easier on the clinicians and case managers.
Welcome to Deep Current. I'm Andy Monge from Motions Code Experts, and today I'm joined by Deidre Rolli. She's a Senior Director of Partnerships and Growth at MyLaurel. So MyLaurel works in one of the most important areas in healthcare right now, helping health systems and payers deliver acute and transitional care in the home, improving patient outcomes while creating more capacity inside hospitals. Deidre, welcome to the show.
Thanks for having me, Andy. It's a pleasure.
The pleasure is all mine. So before we get going into MyLaurel per se, I would love to get to know a little bit more about you and your background and how do you end up working in this partnerships growth and
Sure.
inside the healthcare innovations sector.
Yeah, it's an interesting story. So I'm a nurse by background. I spent about 25 years at an academic medical center in emergency medicine, having leadership roles in that organization. And then after COVID had hit, the focus really became on how can we take care of patients outside of the four walls of the hospital or the institution. So I was tasked to help stand up what's called Hospital at Home, which was a new care model here in the United States for the organization. And we were able to deliver acute care inpatient care in the home and found great success. I worked with an RPM vendor that was supporting the patients in our program. And I started to work for that company as a consultant as more and more organizations wanted to deliver care in the home. So I became a consultant on that end. Have the opportunity to work with a company called MyLaurel, and our concentration really is not on the inpatient criteria, but more on the discharge side. So we're taking low to moderate acuity patients out of hospitals early, couple of days early on their length of stay and continuing them on a journey with us and ensuring that they have all the transitional care needs that they need at home.
That's amazing. You already answered what my next question was what's MyLaurel about, but you already did. So my follow-up question would be, when people hear care at home, they may think of traditional home health, right? But it seems like MyLaurel's focus on a higher care or like a little bit different. It's more on the transition, taking people sooner to their homes and helping them avoid unnecessary hospital utilization as well. Can you explain the difference?
Sure. So home health, it's not my background, but I can tell you what I know is home health agencies really are looking for patients that are stable, that are looking for more of transition back to a primary care post discharge. They're done with their acute episode and they are laterally transitioned into the home health space, where that may include nursing services, but it's usually a physical therapy, occupational therapy, more of transitional care opportunities that are post discharge set up by the hospital. MyLaurel actually is doing the acute transition. So thinking of patients that still need acute interventions such as IV antibiotics, or if you have a chronic disease that is still in an acute state like congestive heart failure, we're able to still give you the medications that you would be getting right in the hospital, but we're giving them to you in your own living room.
Perfect. I think that makes it very, very clear. And what does your typical week look like? I mean, for you personally, not like the job description, but for you, like what is my week?
My week, is I do a lot of collaboration across our whole company, working primarily on the sales and growth team as we try to expand our model with other healthcare systems across the country. So really meeting with leaders in the healthcare space, CFOs, CEOs, really trying to explain the benefit of transitioning patients early, not only for hospital capacity and throughput, but then to think about, is satisfaction scores. Patients aren't always happy being in the four walls, and how can we actually improve satisfaction scores at their healthcare system? I also work with the clinical leads at the company, so I know what's going on in the home with my nurse background. That's really a great opportunity for me to know, how successful are they? They're having great success in transitioning these patients, keeping them out of the hospital. So, meetings with that, and then thinking about what's in the future. Where can our company grow? Is there different areas? Thinking with CMS, having new guidelines for post surgical cases. Is there a way that we can support surgeons in their patients' journeys when they're discharged from the home?
That's fantastic. And are you US, global US, or just in a certain
No,
sector?
so we currently we serve the across the country. We currently are in the markets in the Pennsylvania, Texas, Seattle, Louisiana. So we're growing. We're still is a Series B company, growing and growing fast.
Amazing.
Yeah.
Congrats. Hopefully you can keep delivering that service all around. That sounds great. So what's the biggest misconception health system or patients have when they first start thinking about moving more care into their home?
I think it's twofold, Andy. As patients think that if I'm sick, I need to be in a hospital, right? And that's always been traditional care here in the United States. If you look into Europe, a lot of care is really done in the home. But that's what patients think. I'm acutely ill. I need to be where everyone can see me at all times. And if I think about it, and over my years, is patients become very deconditioned in the hospital. They're restrained, not they're, kept into their room. They're not out, especially post COVID, they're not out walking hallways. They're really staying in the bed, in their hospital beds, which is, giving them a higher risk for infection. So this is one of the things that I like to try to explain, when I'm talking about care in the home. Sometimes it's better to get home, get back into your normal routine where you're not losing strength of your muscles or becoming at risk for infection. On the flip side, like, what do clinicians think about transferring patients home? Is before I got into the hospital at home space, I never would have thought that you could take care of patients that were really sick at home. I was not a believer until I was a doer. And I think that bringing my confidence and knowing my experience to let leaders know, or to let physicians know, you know what? It's better for the patients to go home. There's this, like, little piece of ownership that they don't know, like a black hole, like, what happens when that patient gets discharged? I have to let go of them, but is it safe to let go? And I think that's where my Laurel actually sets in, because there's not that gray area of, I'm discharging them home. I hope that they get to their primary care within the next 2 weeks. There's no guarantee. There's no guarantee that within 48 hours that something's gonna happen and they don't come back. And I think explaining that our episodic care that My Laurel offers is a safety net, in a sense, for their patients, and we can actually identify what may be bringing them to the hospital that might be something that's being caused at the home. It could be diet related. We're actually doing deep dives into what's going on in their personal surroundings. Do they have gaps in social determinants? Can they not afford their medications? And so we're able to identify that, where, the physicians, case managers, nursing inside the four walls never have a visualization of what goes on outside of the hospital.
That's great. And actually, you just touched a point of my personal experience. I mean, I've had a lot of people that I know that end up getting bacteria in the hospital, or as you said, infections, or they get sick with a different illness, and then it combines, and it's so it makes a lot of sense to try to send people home to first release the beds, right? Release the room or the space. And if you can control it in a safe environment, they can actually be happier, improve a lot better. I mean, that's my my opinion, but I'm not an expert.
Well, it's proven, it's a proven model now, and it's just a matter of getting more adopters of the adoption of this care model.
It makes sense. And speaking of, I mean, there's a lot of hospitals or clinics that are under pressure from ED boarding, right? Limited bed capacity, staffing shortages. And what does care at home how does how does care at home fit into the bigger capacity problem nowadays?
Yeah, if you think about, especially in the US market, is emergency rooms a lot of times have turned into primary care clinics or primary care spots because there's such an access issue. And so not only are you filled with patients inside a department, but you have waiting rooms that are filled. It's not uncommon to have a 4, 6, 8 hour wait to even be seen by a physician. And so if you think about somebody that has a true emergency, they may be waiting in a waiting room because somebody that is boarding or, needs to be in the hospital but can't get upstairs to a bed because it's the hotel's full. You don't make reservations when you have an emergency to
Of
get
course.
a spot. And I think that maybe this is confusing on how I'm going down the road, but I think that opening capacity in an inpatient unit then opens capacity for the ED patients to go up so your waiting room can empty so that there's there's a flow, and that's what there's a flow of the patient in a timely manner, and I think that that's what's lacking right now.
I agree 100%. And associated to that, what problems are health systems usually trying to solve with this? Like the booking or the space mostly?
It's there's a lot of different components of what organizations are trying to solve. It's decreasing the length of stay because they know that, is CMS puts guidelines on how long a particular illness requires hospitalization. So they will pay. So think about the profitability. They only pay for 3 days, even if the patient ends up staying for 5 days. So we think about there's loss of revenue if your patient is increased length of stay. So from a financial standpoint, your hospital is losing revenue. Then if you take it onto the flip side of the access point. You may have patients that need to be seen in an emergency room. The wait's so long, they leave. So now you've missed that capture of revenue. So I always like to tie it back to finance. As we think about hospital systems, it is they're a business. In good, bad, it's a business. And you need to figure out what is the best for your buyers. I guess I'll call patients buyers. Is their experience, the customer's experience, good at your organization, or is it not good because they sat 2 days in an emergency department?
Yeah, I got
I
it.
hope
No,
that
and
answered your question.
it does. And associated to that, I mean, how do you know? You already said it, right? There's some like specific times that a certain illness has to stay in the hospital. More than that is just extra care as per the insurance companies. But how do
I
you
don't know if
know?
it's extra care or they, is they've come up with this methodology that this diagnosis is this many days, this diagnosis is that many days. And if there's complications on the way, then you
Yeah.
have to prove that there are complications.
Okay, that makes it tough. So how do you know if a patient is a good fit for care at home?
Yeah, is we partner with the organizations, and we actually will embed our staff into an organization so that they're working directly next to the
Okay.
provider in the hospital, looking for patients that are stable, vital signs are stable. We have a criteria of how to take patients home. They have to be an adult, have a safe, semi-private, doesn't even need to be a home, but needs to have somewhere where they can safely be taken care of in a semi-private area. They are on the trajectory of only needing a couple more days of acute care. And then, as we know, we do not have psychiatry or on our staff right now. So it cannot be someone that is in an acute psychotic episode.
Okay, got it. And I mean, everything from the outside, it sounds simple enough, right? Like let's let the patient recover at home. But operationally speaking, I can't imagine. It might be much more complex, and it can be a mess. So, what does happen behind the scenes for a transition to be safe and reliable?
Yeah, we rely on, I know that AI and everything is and technology is such an important part of healthcare right now. So we do rely on the electronic health records in chart reviews, pulling the data from the organizations themselves to make sure that this patient meets our criteria. So we've whittled it down, narrowed it down using tools that are already in existence in their own health records at the hospital.
Okay. And who needs to coordinate? Is the hospital or the clinic with you, with the home, or how does it work?
Yeah, so a typical care episode is, let's say that I've partnered with Andy's hospital and you're a case manager or you're a physician in the hospital, and I am the representative from MyLaurel and I'm a clinical liaison working from MyLaurel. So you would know me because I would be working on your unit.
Okay.
And so I would run the list as you're doing your rounds in the morning. I'm right there with you doing your rounds in the morning. And then I'm saying, this patient looks like they'd be a great candidate to come home with the MyLoral service. And we take that, I don't want to say it's an administrative burden. We take that off of the hospital staff. We actually go in and we talk to the patient, we talk to the caregiver. We make sure that they understand that when they're coming home with us, that we will be going into their home and caring for them in their home. And we take care of setting the appointments. And on the opposite side, the physician will just need to write a discharge order, discharge to my Laurel.
Gotcha.
And I will say, is we're not only just giving care, we're doing transitional care too. So we're setting up specialty appointments, primary care appointments. We're making sure that they can actually get to their primary care. So if there's problems with driving or obtaining rides, we're finding all of that. Like, so think about social things that may deter patients from being able to get care. We take care
Perfect.
of that too. Yeah.
So basically, your embedded medical specialist inside the clinic is the one that assesses and says, "Hey, I think we should recommend this using my Laurel service."
Yeah, so I would overall say that we are a mobile medical group. We're run by physicians. In the home, it's either nurse practitioners or paramedics that come into your home. They're overseen by a physician. Our physicians are either hospital medicine, internal medicine, emergency, infectious disease, all board certified. And then we transition the patient right back to the healthcare system. So if it is part of your hospital, I'll make sure that their primary care follow-up is back to your hospital. So we're tying everything in.
Got it.
And we don't have to present ourselves as My Laurel. That's another great thing is we can just say we will white label. We can say we're part of X organization.
Makes sense. Okay,
Yeah.
perfect. Yeah, that gives me a clear picture. Thank you so much.
Yeah.
So your role is focused more on partnerships, right, and growth with different clinics or health
Yeah,
facilities.
I would say more hospital systems than clinics. So we try to partner with
Okay,
hospital systems that, not only have inpatient beds, but may have ACO groups or primary care physicians that need somewhere to escalate a patient that may not be doing well and they can't fit them in their schedule this week and to divert them from an ER. They may call us, their nurse call line may triage the patient and say, you know what? Let's contact MyLaurel and let them get out to the house and do an assessment so the patient doesn't go to the ED. Because
got it.
more than not, a complex patient presents to an ED, then ends up in an inpatient bed.
Okay, that makes sense. What makes a good health system or partner from my Laurel? Is it partnership? Is it leadership? Is it operational pains? A willingness to change workflows? What is like the trigger there?
Yeah, I think that I love to work with open-minded, innovative leaders, and I think that that's the majority of the health systems that we're working with now. They're looking to transition how things are being done because they're getting kind of caught behind the 8 ball in a sense, is they know that operationally things aren't working because there's such a higher, demand for care right now. I like to say that we don't wanna change internal workflows that are going on in the hospital, we want to enhance them. So that's why we embed ourselves on units or in ERs to help, transition and make it easier on the clinicians and case managers.
That's fantastic. And what does usually get like a health system or I would say like a patient interested in this model? Is it like financial pressure, the patient experience, the capacity? I mean, we already talked about a lot of this, but is it all of the above?
All of the above. I think that the majority of systems are really struggling right now. You have to think that they're saying that, in 2032, the nursing shortage is going to be absolutely incredible, right? And so AI is coming into the picture, but patients still need to be cared for. They can't be cared for by a computer system. And I think that's what, a lot of companies are trying to solve. Take time off of your providers in the documentation so that they can give real care. But if the numbers are actually going down on how many nurses and how many people are actually going into certain fields of medicine, you have to kind of solve for both.
Yeah, of course. No, there's a lot of there's a lot of innovation that goes behind it, right? I mean, as you were saying, it can solve a lot of operational it has a lot of operational issues, but it solves a lot more bigger operational issues.
100%.
So when a new partner comes on board, where
Mhm.
does the implementation usually get hard? Is it hard? Is it like the clinical workflow, data sharing, patient IDs, or I don't know. That's
It's
a
when we're
general
doing when yeah, no, when we're doing implementations with an organization, we make sure that we've already identified who their leads are internally so that we've made a partnership with, let's say we want to work on ED throughput, right? So we're going to have an emergency department champion that's going to help us build the workflows. So then they can assist with change management in their department. So we make sure that we've laid everything out, what we do, what we offer, we educate it. We'll do a soft launch and then we follow metrics. So we'll launch, we'll do a 30-day check in, a 60-day, and then we'll look at that 90-day. Are we growing? Are we meeting the KPIs? Are you saying that you want to make sure that we can take, say, 5 patients by a day out by 30 days? Have we met that? And then we make sure that we in the implementation that goals are realistic because Laurel has a very interesting model and I've touched on it and people really get surprised is we are going completely at risk when we take patients from our organizations. So if they come to us and we care for them in the home and they transition while they're in our episode back to the hospital, we don't we don't get paid.
okay.
That's how confident we are that we can safely take care of patients, make sure they have great outcomes, and make sure they're not returning to the
Got
organization.
it.
Yeah.
That's very impressive, admirable, to say the least.
A
And
lot
is
of
the model?
say we have a lot of dedicated caregivers
Yeah.
at our company.
No, and it's very interesting because if you're partnering first with the leads and ensuring that to make that transition to in-home care
Mhm.
smoother, analyzing what their triggers are and being able to identify the workflows beforehand, you're minimizing that risk. So it makes sense.
Yeah. And I
So
think
is
on
this model like in this model it seems like critical that patient identification is like spot on, right? Do you need to know who is safe and appropriate for home-based care and who needs a higher level of intervention maybe? And do your teams identify these with the leads inside the hospitals or with your embedded medical specialists?
Yeah, so so usually organizations will want to start with a cohort of patients we'll start with maybe one certain diagnosis. Like we've got a very, very robust congestive heart failure program. So we've successfully shown that you can take patients home, still give them their treatment in their home and follow them with daily weights right in their house and keep them successful. Key being is that you're educating the patient at home where there's really not time for education in a hospital setting, and we're identifying what's going on in the house. So, CHF has been a really big cohort that we've done, especially in the length of stay reduction program that we offer. But I would also say that patients are complex. They may come in for one thing, right? But there's so many patients with so many comorbidities. Our average patient is on 13 medications and has more than 2 diagnoses that we're able to take home. And that That is what it is. Here in the scape of healthcare is people don't just come in with one diagnosis. They have diabetes. They may have congestive heart failure and diabetes and chronic obstructive pulmonary disease. Like there's all sorts of different things. That might not be what drove them to the hospital for an acute case, but we have to manage all of their comorbidities.
Of course. Yeah. No, it makes a lot of sense. And it also depends on the type of patient you're taking care of. If it was someone young that had a terrible accident, it's different than if it's an older patient that is just having multiple conditions. So I
Right.
understand completely.
Yeah. And then I think about, there are patients that need IV antibiotics for a cellulitis in their leg. So that might be 5 days of IV antibiotics. Other than that, one infusion, they don't really need anything else of higher acuity. Are they just taking up a bed in the hospital to get an antibiotic once a day? Like that would be an ideal patient to transition home.
Sure. And what role does technology play in this, in making this care at home scalable? Not the technology for the sake of technology, but like the tools that you need, using dashboards, coordination, patient engagement, so on and so forth.
Yeah, so we have a I'm going to call it low touch RPM. So our patients aren't on continuous remote patient monitoring, but we do have Bluetooth devices that feed back to a platform that we use. We have a care coordination platform of our own so that we know when a clinician is in the home or what time their visits need to be. Also, we have a library of resources that our care management team uses, local resources.
Okay.
So if they need Meals on Wheels or think of community resources that they're aware of. But then on the other side is we rely on the electronic health record and the AI tech that the organizations are already using themselves.
So you
So
connect yourselves with the EHRs inside the systems of the hospitals?
we do.
Perfect.
Yeah, we do.
Makes sense.
Yeah.
And when you talk to health systems, what outcomes matter most? Is it that readmission? You said it's not a possibility. They cannot be readmitted. But the length of stay, utilization, cost of care, what gets their attention? Sorry, I'm gonna ask that again. What gets their attention more?
As we go in and we say, we want to help you solve your problem. What's keeping your organization up at night? Is it your length of stay? Is it your ED borders? Or is it that you have such a high risk population that your top 30 of patients that are discharged, your sickest patients that are being discharged are turning around and coming right back in within a week. And so these high utilizers, is that your pain point? And sometimes it's all, sometimes it may just be one, but we really let the partnership define on where can we help? We're here to help you solve this. And we have a great opportunity, a great care model, and we're proving success.
Fantastic. Looking forward into the future. Let's go to the final section of the podcast. If you
Yeah.
could change one big thing about health systems, or how health systems adopt new care delivery models, what would it be? I know it's a tough question, so I'm going to give you some time.
Yeah, that's a really tough question. So let me make sure that I understand what you said to me and let me just repeat it back. If I could change anything in the future, and maybe I'm not wording this right. If I could change anything in the future to assist health partners, tell me again.
No, it's if you could change one thing about how health systems adopt new care delivery models, what would it be? Like basically in-home care is a new model per se. It's
Yeah.
not the standard, right? So if they could adopt this more or something different, what would it be? If you don't have an answer, we can just skip.
No, I do have an answer because I think that organizations have to realize that critical care patients need continuous high touch monitoring. Post surgical patients need high touch monitoring. That is should the way that I think about it is that's what a hospital should be reserved for. Is your more critical patients needing more interventions, needing life-saving interventions, where patients that can be managed in their home safely like I said, should come out because you do see that, is like I said earlier, there's a high risk for infections. They more patients stay in a hospital, the less mobile they become. There's just a whole cohort of things that can happen in a 5-day hospital stay.
Makes a lot of sense. Think where you think care at home is headed over the next 5 years.
I think you're going to see more and more care taking place in the home.
Easy.
100%. I think that that's the push. That is the push for, since COVID, I think that there's been a lot of live and learn in organizations, and it's safer to get patients home earlier and to care in place.
It makes a lot of sense, and it's I think it's more noticeable nowadays where people are like it just reminds me to going back to I think it was this movie. It's not only a movie; it's a real story by Patch Adams from where he tries to keep people happy, right? And
Yeah.
people are happier at home, and that's what I believe. And if they're with people that they care of, especially if you're like in a hospital that doesn't allow visits or many visits, and it's very complex. I mean, it's just being there as a patient, lonely in a room. It's not like the most. I don't know what the word is, inspirational, right?
Right, right. And, is they miss their pets. Like that you think life goes on. You may be in the hospital bed, but life is going on like at your house. And there are things that, you're gonna miss out on. You not well, is I've had patients come in and say, I can't stay. I have two cats at home and I don't have anybody to feed them. Like they're more worried about like their pets. And can you get them home to their pets? Absolutely you can. Or, is a lot I will touch on, is it's if you think about non-English speaking patients and their experience in a hospital or patients that have dementia and they're not in their environment. It is a very, very difficult hospital stay, not only for the patient, but also for the care team, is to be able to bring them back into their environment where there is family and there are resources of people that care about them and making sure that their caregivers understand what's going on with their care because I could go in and tell a patient something using an interpreter service, right? And but the other family members aren't there, so they don't hear it. And so then the patient's trying to tell their family, and it may not have even been the right statements that they're saying. So having everybody involved, and this may not be pertinent to what we're talking about, but I think that it's important to understand that it's not just the patient, it's also the caregivers that need to know what the trajectory of an illness and including them in. And they're not there when the doctors are rounding at 7 in the morning or the nurse is giving a medicine at 8 o'clock at night.
No, I love it. I love it. What's the most overrated thing in healthcare innovation right
The overrated thing in healthcare innovation right now.
Tough?
A tough one because I think it's who are you talking to?
Mhm.
As a nurse, I think AI is overrated because I haven't heard a lot of companies that want to help nursing. But as a radiologist, I don't know, I'd have a completely different answer for you. Like I think that AI has a place in healthcare. I think that it can take the burden off. I'm not going to say it's overrated because I think that it's amazing, but I think that you have to make sure that you have safety nets on it.
I agree. It's especially since you're dealing with people, right? It's
Yeah,
not it's not a
we're not doing
machine.
a replacement.
Exactly. I
Yeah.
agree, I agree. So most underrated problem in hospital operations.
Most underrated problem in hospital operations, patient flow.
I
The
agree.
I would actually say transports of patients within your system. So I'll specify it is how are you making sure that Mr. Smith can get to X-ray when X-ray needs him and get transported back in a timely manner. There's a lot of wasted time in transporting patients. It's care coordination within the four walls.
Logistics behind it, it's
Logistics,
complex.
logistics.
Yeah,
Yeah,
I agree.
yeah.
One reason healthcare pilots fail, if they fail.
I don't think anything should ever be called a pilot, and I will stand on this box. If you say it's a pilot, you're never getting 100% buy-in.
Love it.
I have said this to leaders many, many times. Why are we piloting this? We should call this a soft launch because this is how we're moving forward.
I like that answer. I like that answer a lot. One metric every care at home program should track.
Every metric, every care.
One metric.
I think that it aligns with the same hospital metrics is preventing patients from readmission. I think that that should be completely in alignment.
I love it. What separates a great health system partner from an average one?
System buy-in. You can't just have one department giving 100%. You need the entire system to be a cohesive unit or have the same ideas on where they're moving forward. So I would say if this isn't a one word answer, but I think that goals are set or quarterly goals are set or yearly goals are set, and that should be at a system level on where patients are moving. And I think care at home should always be included at that on that for every healthcare system. Everyone should be thinking about how are we making capacity? How are we moving patients safely to be cared for in their home?
Yeah. No, I love it. And I think it's something that everyone, like the community, needs to start thinking about, right?
Hmm.
How do we move a patient faster away from the hospitals in a safer way?
Yeah, and especially, and I'm going to add this, especially because rural healthcare is such a problem. There's so many hospitals that are closing because of finances that there is less care in rural areas. And so, how are we getting care? And that's more care at home.
And what's the future of care at home in one sentence?
It's wellness,
Wellness. I love it. I love that word.
wellness.
Perfect.
Hmm.
Great. So, Deidre, it was great, valuable conversation. It was great having you here. I appreciate how you broke down not just the promise at Care Home, but the operational reality behind making it work. What I
Yeah.
really liked about this is like how the model touches different important pieces, right, of healthcare. It's like patient experience, hospital capacity, costs. You mentioned the financial impact as well, the outcomes of partnerships, the execution, how everything needs to work cohesively as one a big unit. I love it. So, where can people learn more about MyLaurel or follow what you do and the team are building?
Sure. So we are the company is MyLaurel. We are based out of New York City. We are partnered across the country with healthcare systems, delivering safe, effective acute care in the home and solving problems not only for healthcare systems but giving great outcomes to patients on a daily basis.
Perfect. So
Yeah.
you know where to look for MyLaurel then. And thank you again for joining us. And thanks to everyone listening to Deep Current. Stay tuned for more conversations about healthcare, technology, and the systems behind better care. Have a
Great.
good one, everybody.
Thanks so much. Bye bye.